seniors of the profession, and dear friends. There is a saying which you will never miss in any of the classes on lifestyle improvement or business management, where they say successful people don't do anything differently. It's only that they do regular things in a different fashion, which has a unique value, in fact a unique and very pertinent points regarding the way we have been practicing ophthalmology from our student days, from our junior consultant days, from our senior consultant days, and from our ownership days. Everything has changed. We can understand the surgical theatre has totally changed. Patient mentality has totally changed. Doctor-patient relationship has changed. Consumer protection has added up all the burden. Yet one thing that has never changed is the way we do refraction. We delegate it to the most dingy corner of our hospital center. It is done in a small aluminium partition way. And if you notice, in fact I asked one of the most senior and most successful practitioners in Chennai, he said, I don't change all these things, but these things have sentimental value. He believes it has sentimental value. If you notice the trial frame, it will be almost worn out. Most of the lenses will also be worn out. The numbers in the lenses will be like as numbers in the old typewriters. You just presume that they are -2 and -0.25 will not be much different. And if you are going to do something very more bent like a Jackson cross cylinder, think what you will feel if this is being done to you. Think what you will feel. Now we don't want, in fact, our patients don't want treatment. We have moved from disease management to wellness management. Patients are already well. Patients are very much perfect. They just want improvement on their perfection. That is what they seek us for. At least, if you notice, around 60 to 70% of refraction practice will be for patients who come to you not just because they don't see better. It's because they want something fashionable. It's because they want something which adds on to their professional style and professional output. So in that way, the talk on modern refraction will be how we can change this with the changing times. How we can change this to make it more presentable to our patients. And the first thing I'll suggest to you is a phoropter. A phoropter looks very impressive. Take it from me, if you use a phoropter, you can use it at least in the beginning for all your VIP patients. VIP patients, as we know, are of two kinds. VIPs who are really VIP, and of course the very irritating patients. I use VIP as an acronym in my case for the very irritating patients, or rather the very concerning and very choosy patients who have seen it all. They would have seen at least 3 or 4 ophthalmologists in the area. They know what the strengths and weaknesses of each ophthalmologist in the area is, and so they have come to test you. In fact, you think you are testing their eyes. In fact, I strongly believe they are testing your skills in action and practice. So to do that, change from a regular lens case to a phoropter has huge advantages. The advantages are not necessarily aesthetic. They are of course very aesthetic, but at least there are huge advantages in the real sense that you can put in cylinders, take out cylinders in front of the eye with just a knob rotation. The patient never realizes what is happening. The patient just keeps telling you whether he sees better or not. He doesn't speak anything else. You allow a patient to speak something else other than this. During refraction, you will need an aspirin at the end of the refraction. The patient should only say whether he sees better or not. If you start seeing, put that previous lens doctor, put this after lens doctor, there are one of my patients will say, you put that 4th lens you put before this doctor. How will you ever remember the 4th lens which you have put before this? So all this can be done very nicely with this phoropter. It has everything. It just doesn't have the sclerocylindrical combination alone. It has a stenopic slit, it has an astigmatic Jackson cross cylinder you can use. You can use everything, almost everything in the refraction armamentarium to do a good and neat refraction and to get a good prescription for the patient is available without the patient needing to move out of anything. They can sit in the seat. The patient sits in the seat. In fact, our chair unit today is supposed to have that singular advantage. You want the patient to sit and do everything. You want to do slit lamp, you want to do a 90D, you want to do an indirect, you want to do everything in that chair unit. Probably a day will come in even that cataract surgery will be done in the chair unit in the OP clinic. But the refraction can also be added to this chair unit practice. The patient doesn't get anywhere else. In fact, we can have 2 chair units in our clinic, where one chair unit you speak to the patient and the refraction starts doing the refraction. You can move to the other chair unit and see the next patient. So the patient very much thinks he is well within your purview, not delegated to an ancillary room in your practice where a junior optometrist tries to speak to him and get a good prescription. A video on this will be more enlightening. Most of the things are just movements of the dial. The spheres can be added, the cylinders can be added, cylinders can be refined. You can do almost everything. I think there is nothing that you cannot do with the phoropter which a regular trial set and the regular refraction ancillaries can do. All these can be done with a lot of finesse. Probably you will need to train somebody. I will strongly urge you to get something like this and at least keep it to the most discerning patients of yours. Not necessarily for every patient who comes to your clinic. At least to patients who are the opinion makers in your area, who you very well know that you need to have a good word from that patient. If you have a bad word from that patient, then it will affect your practice. Such kind of a people, you can use this because sure, this will be a difference from the area. The other practitioners might not have it. So that will give you a huge advantage. The second thing I urge you to have is this. I think all of us have slowly shifted to, from the regular Snellen chart, from the drum which we had a cord to pull, from the drum or the regular Snellen chart where we had a stick to show the optotype type. Now we went on to remote controlled Snellen chart. You can use a nice unit which can show you fantastically exactly what you want. The chart projector can show you exactly what you want. You can show the 6-12 line and make the patient believe that he sees 6-6. The patient will not ask you another question. He will never know that there is a 6-6 line. Because for him, the last line is important. You show the regular Snellen chart, you are finished. The patient doesn't get out of the chair unless he reads also the maker of the Snellen chart. Why Snellen chart? And small manufacturer logo below beneath it. And every patient went unsatisfied because they never could read that. So that kind of problems you won't have. And of course these projectors can also project everything you want. You can project pictures for children. He can project optotypes for illiterate people. He can even project Ishihara's chart. He can project fundus diagrams. He can project fundus photography, cataract photography. Everything you want, he can project. So you can also do this mini counseling which you do to the patients, finish off here itself. You can show them, if you see the moderate diabetic retinopathy on the patient, you can throw a picture of it on the screen and discuss with it. And patient might as well think that it is his picture. You need not worry about it. It in fact adds to the effect. So you can throw these pictures and show them what it is. Everything is programmable. One of the huge advantages, our clinic space can shrink. It need not be that original 6 or 3. It can be lesser than that also because these charts can be programmed to the distance we want. It can be to any distance. So that gives also a huge advantage. It can also show you the better charts. It can show you the contrast sensitivity chart if you want. It can show you the ETDRS chart you want. But of course, those things do not apply to regular refraction. But at least, as I told you, to patients who have traveled very much. I see most of our the age-old illiterate parties in my area have gone to US, have gone to Australia, have gone to UK for their children's delivery or something, and had their eye tested there. So they come here and sit and watch whether you do it with that same thinner. And so even the illiterate patients in our clinic today are more discerning and more choosy and more demanding. And in that sense, these charts help. A small video on how it works. There is even an app for it. You can even download it. It nicely shows on the screen exactly what you want the patient to see. He doesn't show everything, so that the patient starts in the back of his mind, it creates a feeling that he should read the last line. That makes the whole consultation between you and the patient that much difficult. Show lines which you prefer to be shown, and the patient will read it, and that way he'll be very happy. Other things slowly we have adapted to already. An autorefractometer we always have, all of us have. In fact, our AR with K we have started having, because once I was thinking, as A-scan developed, keratometry didn't develop. If you notice, A-scan is a more electronic equipment, but the keratometer was still the mechanical equipment. And patients were sat on a keratometer, a K reading was taken, and then a A-scan was done. And that slowly was bit taxing for the patients, because these adjustment of the keratometer, the conventional mechanical keratometer, changed to digital keratometers. And these digital keratometers, as you see in the left-hand corner, are very nice, very, very beautiful. All you need to do is just keep it away from the patient and focus that ring on the patient's cornea. It will auto-sense and take a K and give you a K. And that K will also be very nice, and the axis and all, it will show very genuinely and very fine. But now today, I think most of us tend to have an AR with K. That also gives a very good reading, because most of the patients will go on to need a contact lens, will go on to need a refractive procedure, or will need a IOL calculation. For all these, they are important. In fact, frame selection need not be a frame selection which is done in the real sense, where the patient puts every frame on his face, looks at the mirror. Most of your myopes don't see well, so they put a glass on their face and try to look at the mirror. Somebody has to hold the mirror so very close to them. Or certain times the patient has a feeling of discomfort on their mind, and so the frame selection doesn't get as comfortable, even in a very good ambient optical room which you have. So today we have computerized frame selection. Patient can sit in front of the computer, choose whatever frame that is available in your stocks, and put it on their face and see. Then once they come to a choice that this will suit me, then in that way, that particular model, certain frames of different colors and different sizes can be shown to them, and from that they can do the final choice. Children will get very impressed with whatever I told you. All this will surely impress children very much more than, if not adults, very much more. So attracting and holding on to children patients, pediatric patients are very important, as we all know, because they bring us the whole family back to us. Now, you do a good cataract surgery on the grandmother of a family, not much you will get back. But you treat a good flecular conjunctivitis in the newborn of the family, the family will stay with you. I think I didn't tell you, all of you know that. So to attract the children and to retain that patient base is very important. So slowly we'll have to shift. At least in a principled sense, if not in a real sense. In a mindset change should be there, from doing refraction the conventional way to doing refraction with certain of the new technological developments that have happened in this area. As I told you, if you are interested, you can start it up as at least for certain of your patients, whom you can even charge more. And those patients, if they like it, then you can make it more wider for all your patients. Certain days we'll have one clinic where we'll have everything. We'll do everything almost in that single chamber of ours, as a studio apartment. Today every apartment is a studio apartment. Likewise, I think we will go to a stage where we have studio clinics. Where is the question?